All right, let's finish off our last lecture. It's on occlusion related to removable prosthetics. So we're going to start off by talking about a complete denture. Sometimes we're going to run into patients who, for one reason or another, have lost all their teeth. And us as dentists have the ability to help restore them to form and function. The challenge here, though, is that we're kind of out of landmarks to help us put the teeth where they need to be. So the way we want to explore this is let's first just look at natural dentition and see if we can find some landmarks that are useful that we can then use to help construct our dentures so that we get them teeth that look as normal to normal dentition or natural dentition as possible. So on the right side, we got 4 different things that we're going to look at that can help us map out the position and the orientation of the teeth. So we're going to start with the maxillary arch. So when teeth are taken out, the patient's lip support gets diminished, meaning because of the bone resorption and remodeling that happens after tooth extraction, the upper jaw looks sunken in. So part of the support that the lip gets is actually from the position of our maxillary anterior teeth. If we were to pick a landmark here that helps us determine where those upper front teeth should land, we can look intraorally and find this anatomical landmark, the incisive papilla. So this papilla is just an elevation of soft tissue that covers the nasopalatine canal. And the nice thing about this is that it doesn't really change positions over time. So even when your teeth are extracted, that position of that soft tissue landmark still remains relatively constant. So by taking anatomical averages of patients that have their teeth, we find that the position of the incisal edge of that central incisor is always about 8 to 10 millimeters facial to that incisive papilla. So that becomes a helpful landmark for us to know where to put our denture teeth, and we're going to set that 8 to 10 millimeters facial to that incisive papilla. The other thing we want to look at is incisal edge position. So if we ask the patient to just relax and just have their lips at rest, we get a incisal display at rest measurement. So for younger females, it's typical that they'll have 3 to 4 millimeters of incisal display, and then 1 or 2 for males. But over time, we know just as people age, things tend to sag a bit, and that incisal display decreases over time. And then at times you'll have older patients that instead of having their upper front teeth show, they tend to just have their lower front teeth showing. So we can use that as a guideline to know where to put our upper front teeth. For denture patients, since we have the flexibility of putting the incisal edge wherever we want, a lot of patients do appreciate that we give a more youthful look. So we can extend that incisal edge position to that, on average, maybe 1 to 2 millimeters of incisal display at rest, even though their lips may have sagged a little bit. Okay. We know that the teeth, if we were to look at them, should be relatively parallel to the interpupillary line, right? We don't want the left side hanging lower than the right side. We want those to be fairly symmetric throughout the arch. So from the frontal view, we'll look at the patient and see if their occlusal plane. We want the midline of the teeth to be centered on the face too. So that should be centered. So that should be centered and perpendicular to the interpupillary line. There's a study by an orthodontist, Vince Kokic, where they investigated how far off the midline needed to be before people noticed that it was aesthetically unpleasing. So the upper midline could actually be off by about 4 millimeters before it was noticed as unattractive. The other thing they looked at too was instead of a midline deviation, they looked at a midline cant. So if the midline was skewed, so it wasn't straight up and down, but if it was off center at an angle. Now, if there was a midline cant of just a millimeter, that's noticed pretty much right away. So the idea of having the teeth perfectly centered on the facial midline, there's quite a bit of leeway there. You can be off by about 4 millimeters before we start to notice. The other parameter we've looked at before is this occlusal plane from the sagittal view. We know that it slopes up a little bit. If we use some extraoral landmarks, we can use the ala to the tragus, so that's the side of the nose to the ear, and that plane approximates our occlusal plane from this sagittal view. Okay. So, with all those things in mind, we want to figure out a way in which we can very quickly kind of capture all these parameters in a patient that doesn't have any teeth. So the way that this works is we end up making the patient's mouth, and then in the center photo you can see that's the stone model that's poured from it. And on that stone model we make what we call a wax rim. So the base of it is a hard acrylic, and on top we make a rim made out of wax. And you want to think of this wax rim as sort of a prototype or a template for our teeth. So this will help us establish those parameters that we had talked about prior. So what we do is we take this wax rim and we can place it in its mouth and evaluate all those things that we're talking about. What is the incisal edge position like? Is it parallel to the interpupillary line? How is it to the allotragus? Does it give us sufficient lip support? So this wax rim, since it's made out of wax, you can very easily subtract to it. One way to quickly subtract wax is you can heat up this wax spatula, and then you just place it onto the rim and it'll melt in a flat plane, so you can correct any discrepancies if things are uneven, or if you just need to quickly reduce the height of the wax there. So when we have the upper wax rim completed, this really serves as a template for where our teeth should go. So incisal edge, lip support, allotragus, interpupillary line, those things are all established and captured in this rim. And if you think about it, our lower rim can also be made, and for the most part, all those parameters that we had figured out, they'll match up with the upper. For example, we know that the rims should be parallel to the interpupillary line. So if you make the lower rim just match up to the upper rim, you know that those things coincide. And then the allotragus, or the occlusal plane, from that sagittal view, that's established on the upper, and then really the lower teeth really just need to match up to the upper teeth. And then with the lip support and the position of the maxillary anterior teeth, we know that those mandibular anterior teeth are just set just a little bit lingual to the position of the upper central incisors. So the premise here is that once we have the main parameters of the upper rim squared away, the lower rim can be made to pretty much match up to what we've already established. Now the one we do need to figure out, and the only variable left to determine, is what is the height of this mandibular rim. Okay, and in order to determine that, we have to dive into this concept that I want to introduce you to. on vertical dimension. So vertical dimension of occlusion, this can be thought of as a distance between jaws when the teeth are in occlusion. So basically you can think of it as how far the jaws are when the teeth come together. And you can measure intraorally, so you can measure, for example, from free gingival margin to free gingival margin of the upper to the lower, or you can use some extraoral landmarks. Typically you measure from the chin to the nose. That's an easy way to kind of measure extraorally. So this distance is significant if we were to compare it to what we term the dimension of rest. So remember, the vertical dimension of occlusion is when our teeth are together. What is the distance between the jaws? Now, when you are just sitting there in a very relaxed position, almost as if you're dozing off and about to fall asleep, naturally our teeth are separated in this rest position, or this physiologic rest position. Now, on average, that distance that's the teeth are separated by is about 2 to 3 millimeters of space. So what we do know over time is that this vertical dimension of rest stays pretty consistent even when our teeth are removed and extracted. So in the denture patient, we literally don't have any teeth to obtain this vertical dimension of occlusion record, right? Because they're fully edentulous. It's not like you can ask them to close their edentulous jaws together and have it stop. But we do know that from the vertical dimension of rest position, so if you ask the patient to just relax their jaw, almost catch them as if they're about to fall asleep, that measurement, if we subtract 2 or 3 millimeters from there, should establish what our desired vertical dimension of occlusion measurement should be. Okay, so the difference between those two is what we call the freeway space. And on average, we want a 2 to 3 millimeter difference of this freeway space. Okay. So it becomes a very useful reference for us to establish how tall to make this lower rim. The height of the lower rim should be adjusted so that we get a 2 to 3 millimeter difference from the vertical dimension of occlusion and vertical dimension of rest. So since the patient doesn't have any teeth, we can put these two wax rims to kind of function as teeth, and we'll pretend that those are the teeth the patients are occluding on, and then when the patient closes together, the rim will hit the rim, and then that will establish our vertical dimension of occlusion. And of course, since it's made out of wax, we're able to very easily add or subtract to the height of that rim to get it to that 2 to 3 millimeter difference. And what I'll do right now is I'll put in a quick little video that kind of demonstrates this point on a patient that we had in the clinic.
What we'll instruct the patient to do is lick their lips and swallow. You just have your jaw kind of relax, lips just slightly apart right there. Perfect. So this is the patient's vertical dimension of rest, or their rest position. So we line up the two dots and we've made marks on our stick. So that top one to that line, that distance is our VDR. Okay? And we'll do it a couple times just to verify that it's repeatable. So why don't you do that one more time, lick your lips, swallow, and just let your jaw hang just a little bit, lips just slightly apart. Perfect. So we'll line up the lines again, and that looks pretty close. So now we want to evaluate his vertical dimension of occlusion with his existing dentures that he came in with. So we'll take that out and we'll put the old dentures in. And generally the anatomical average is that there's a 2 to 3 millimeter difference between vertical dimension of rest and occlusion. Go ahead and close together. So when the teeth are together, this is his vertical dimension of occlusion, VDO. And we'll take the same stick here and we'll do a little measurement there. So where I've drawn this line to this upper red line is his existing vertical dimension of occlusion. And the difference between his VDO and VDR is about 6 millimeters, maybe 7. So that's a lot more space than sort of the anatomical average. And if we look at his facial profile, his lower third, we can see that it's collapsed a little bit. So now we have the wax trims that we've adjusted to the appropriate dimensions. So we'll put those in. And what we want to see is that when the rims are touching or occluding, go ahead and close. So this is his new VDO that we want to get him to. And you can see the facial third is a little bit more open, or that distance is a little wider. And now when we do that same measurement, he's closer to this black line that we have right here. Okay, so now the difference between his vertical dimension of rest and his new vertical dimension of occlusion is closer to the 2 or 3 millimeters that we're looking for. So we've essentially opened up his vertical dimension, and that happens. Patients will often lose vertical dimension because of the acrylic teeth on the existing dentures. These will wear down over time, so the distance between the jaws gets closer and closer to each other.
Okay. One of the things that happens when a denture patient wears their denture for a while is that they can have what we term a loss of vertical dimension of occlusion. And that's because the patient ends up grinding their teeth down, right? So as the teeth are worn down, the distance between the jaws get smaller and smaller. Now, with what we term a collapsed vertical dimension of occlusion, they often present with a shorter lower facial third. And as you saw in our video, our desire was to restore that patient's vertical dimension of occlusion to something that's more appropriate and more aesthetically pleasing. So the patient may have started off in this situation with an ideal freeway space, but over time, because of the VDO was decreased. So now we have a freeway space of 6 millimeters. So in order to restore them back to where we want them to be, we need to increase the vertical dimension by about 3 millimeters to get them back to where they started from. Now, this same principle applies to patients that have teeth, right? So tooth wear can happen on a denture as well as on patients who are dentate. What I do want to point out, though, is that not every single case that you see where you observe tooth wear, you would conclude that the patient has lost vertical dimension of occlusion. One of the things that can happen is something called compensatory supereruption. So what happens is, even as the teeth are worn down, if the rate of the wear is slower than the rate that the tooth supererupts, then you actually do not lose any vertical dimension of occlusion, even though clinically it looks like you should, because when you observe the teeth, they look much shorter. And one of the dead giveaways to this is this supereruption is looking at the gingival zeniths of teeth. So if we actually go back and look at what the ideal gingival zeniths of teeth, we can see that the gingival height of the canines are at about the same level of the central incisors. And then the gingival zenith for the lateral is about 1 millimeter more coronal. So if we were to look at the lines, we would say before there was tooth wear, the gingival zeniths follow the pattern of those lines. And as teeth started to wear down, the teeth started to drift down, and along with the drifting, there was the deposition of bone and the gingiva that kind of grew down with it as well, thus having such a dramatic shift in the gingival zenith of those teeth. So vertical dimension of occlusion and wear cases generally are seen, but we do want to go through the exercise and ask the question that is there compensatory supereruption, and maybe this isn't a classic wear case. What you do find that is common is erosion cases because of how quickly the GERD, or let's say bulimia, wears down the teeth. Those cases, typically you see the wear of the teeth much quicker than the rate of supereruption. Whereas in general attrition cases, that's not always true. Okay, another clinical scenario that we see the loss of vertical dimension, or the loss of vertical dimension, is when we lack posterior support, right? So when posterior teeth are taken out, the anterior teeth undergo primary occlusal trauma, and then they end up in some sort of pathologic migration. The anterior teeth get kicked out and forward, and then their bite starts to collapse. Okay, so now that we've established the upper and lower rim, so we've used those wax templates to know how where the teeth should be positioned, we have to answer the question, how can we capture the patient's jaw relationship when the patient closes their teeth together? So if we think of this denture patient with these wax rims, this is much different than a patient that we're kind of accustomed to seeing that has teeth, right? We had talked at length about this maximum intercuspation, where there's pretty significant interdigitation of teeth that make it easy for us to have a endpoint position that's consistent and repeatable and kind of lock itself in. The challenge with the denture case is that the rims, although they give us a good idea of where the teeth should be, they're made to be perfectly flat. So when you have two surfaces that are perfectly flat, you ask the patient to close down, well, there can be these horizontal discrepancies that lead to a very inconsistent bite. So what you can see, if you just instruct the patient to close together and then repeated that a few times, you would find that the patient would touch the rims at different orientations, and that their bite isn't consistent because they lack the tooth-to-tooth contacts and that neuromusculature feedback that helps them know where to position their jaws relative to each other. They kind of get lost because there's no longer any teeth, and there's no teeth with any nerves and PDL to give that sensory feedback. Okay, so with that understanding that we have a difficulty achieving a repeatable bite because of the lack of tooth contacts, we have to employ a different strategy to get the patient to repeatedly close in the same way. Okay, and the way we do that is we have to, instead of using the teeth, we're going to use their joint position as our reference to help us get a repeatable bite. So let's go back and look at our TMJ. And let's dive into this. So taking a look at the joint relative to the mandibular fossa, the textbooks always show the joint situated perfectly in the fossa there, where it looks like the condyle is like perfectly seated in that endpoint position there. But really the reality is that when our teeth are closed together in that maximum intercuspation position, if we were to examine and take, let's say, an x-ray of where a joint is or a condyle is relative to that mandibular, we'd actually find that the majority of us, 90% of us, that condyle is not in that endpoint position. It's actually probably a little bit lower and a little bit posterior to where those photos depict they occur. And the position of the condyle in a different position than the endpoint position is not a big deal. In fact, most of us, since we exist that way, is a very perfectly stable position, and it doesn't pose a problem for occlusal stability. Okay. That endpoint position, let's go ahead and define. So the endpoint position is referred to as centric relation. And what it's referring to is when the condyle is seated in the most anterior superior position of that mandibular fossa. So if you were to kind of take that condyle and gently push it up and back, so if you take that condyle and you start to seat that condyle, then you'll find that so if we ended up pushing on the mandible, we could actually help guide that condyle into the endpoint position. So when that happens, the condyle has a tendency to rotate up and forward, so that ends up in that most anterior superior position. Okay. So when we look at the bite and obtaining the bite record, how the upper and lower teeth come together, since the patient doesn't have any teeth to help guide the closure, what we can do is we actually end up putting a little gentle pressure on the chin here, and that helps guide the patient's mandible and the condyle into that centric relation position, which is the most anterior posterior, the most anterior superior position of that mandibular fossa. So the condyle will shift up, and because the mandible rotates, it will rotate into that anterior superior position. Okay, so that becomes our endpoint position, and that's really repeatable, right? So if you think about like your elbow, if you were to bend your elbow, you can bend and have the arm at different angles, but you can't really replicate the, let's say, like a 35-degree angle consistently every time. Sometimes you'll be at 38, 37 degrees, but if you pick the endpoint position and all you did and you said, oh, I'm just going to extend my arm just straight, so it's 180 degrees, well, that's really repeatable because that's an endpoint position that you can go to every single time. So that's the same concept with putting the condyle in the most anterior superior position, also known as centric relation. So once the condyle is seated in centric relation, then it can just undergo a pure rotational movement until the rims together. Okay. So this is how you are to obtain a patient's jaw relation record. Okay. So how the upper and lower jaw comes together. And it's important to get a repeatable position for this closure, because each subsequent appointment that the patient comes, we're going to repeat and try to verify that the bite is correct. So after this visit, the next clinical visit is actually trying in the denture with teeth set in them. Now, if the bite isn't repeatable, the next time they come in, their teeth may shift and may hit in a different position. So our job is to kind of guide them into that centric relation position every time we perform some sort of procedure. until they get through this denture process. And then once they wear their denture for a while, then their muscles really accommodate and they learn how to close so they can consistently, repeatedly come into that and the tooth-to-tooth contact. So it's predictable, okay? Because remember, we're starting out with a patient that has no teeth at all, and we're trying to build them to a set of teeth. So once they have a set of teeth that they can use, then we can reestablish a MIP position with the denture teeth. Okay, another strategy to help that seat that condyle into centric relation is to instruct the patient to lift their tongue to the back of the roof of the mouth. And because we know that the insertion of the tongue muscles, some will insert into the anterior part of the mandible, when you lift the tongue up into the back, that also helps seat the condyle into that endpoint position. So it's a similar thing as just gently pushing on the chin to force their mandible back so that it'll rotate into that anterior superior position. Okay, so you can actually try this. If you stuck and put your tongue to the roof of your mouth and then you gently close together, some of you are going to notice that you're going to feel a point of contact, so tooth-to-tooth contact that will occur first before the rest of your teeth come together. Okay, so that first tooth-to-tooth contact is not your maximum intercuspation position. That is a tooth-to-tooth contact that occurs when your condyles are in centric relation. And then if you were to squeeze your teeth together, you would go from that one single point of contact, and then you would slide into your maximum intercuspation position. So you can go ahead and try that and see if some of you can experience the difference between your maximum intercuspation and then when your condyles are in centric relation and where your teeth come together when your condyles are in that endpoint position. A couple other things about the mandible. So one of the things you need to know is that when your lower jaw opens and rotates, for about the first 20 to 25 millimeters at opening, it undergoes a pure rotational movement. And then after that, once you get beyond a certain point, then it'll also translate down the articular. Okay, so as we open, it'll translate down. So there's some photos here to show you this process. It's just a pure rotation around the hinge axis, the first 20 to 25 millimeters. But then as you go beyond that, you'll notice that the mandible continues to rotate, but it'll also have to translate down. So when you're yawning real big, you'll probably have some rotation and translation of your mandible, that articular eminence. Okay, so we've explored a lot of the parameters of the dentures and how we can get them to look like natural teeth. But one of the things we do need to talk about is how should the teeth or the occlusion be different in dentures versus natural dentition. So if we were to apply occlusal concepts to dentures, we would run into a pretty big problem, right? So whether it's canine guidance or group function, we are essentially tipping those teeth in the denture because we don't have contact on those teeth on both sides of the arches. So the main difference between dentures and teeth are that the denture teeth are all connected to each other, right? They're all connected to this pink denture base. So it's not like the canine functions independently. So the whole reason why the denture stays in place, especially for the upper, is because of a peripheral seal. It's really a suction cup effect. Now, if you take, for example, a canine, and then you just took that one tooth and loaded it in a horizontal direction, well, it's going to cause a tipping motion. and that tipping motion is going to end up dislodging the denture. You're going to have air leak in and then break up that seal, and then the denture will drop down. So that's not ideal. So the change that we have is that we want the denture teeth, especially so we want to set up the denture teeth in what we term a bilateral balanced occlusion. Okay, so which means that when you move your jaw or your teeth side to side, we should have contact on both sides. And that provides the denture some stability so you don't introduce any tipping forces. So remember, in our natural dentition, we had mentioned that any balancing interferences were detrimental. But that's a whole completely different story when it comes to denture occlusion. This is actually helpful because it helps stabilize the denture and it doesn't introduce any tipping forces. Okay. So when we look at the anterior teeth, the teeth should also be in what we call a protrusive balance. So when the patient slides their jaw forward with their dentures, we want their teeth to come in contact evenly, front and back, so again, we don't introduce any tipping forces. And in order to achieve this protrusive balance, especially by the time when the patient gets to the edge-to-edge position, meaning the incisal edge of the uppers come in contact with the incisal edge of the lower teeth, that position, you want the back teeth also to come in contact with each other. So the best way to do is by actually setting the anterior teeth with a slight overjet here. So about 1 to 2 millimeters where the teeth are actually not in occlusion. And what that does is, as you slide your jaw forward, it allows some room for your posterior teeth to then come in contact before the anterior teeth start this tipping motion. And this is what we term as protrusive balance. Okay. All right, we're gonna finish up with real quick just this last little scenario. Most of this was on the completely edentulous scenario. What we also have is situations when we're just place a segment of a patient's teeth with a removable prosthetic. And then we do this with a removable partial denture, or an RPD. So you can see here, the patient still has some of their teeth, but needs some help with restoring multiple missing teeth here. Okay. What is kind of typical to see is that the patients that have missing posterior teeth, and they do have a maximum intercuspation position, so they have just enough teeth where the teeth will interdigitate and they can consistently go into that same bite every time. So that's good because they can consistently bite together, but this does pose a bit of for us in the sense that if we were to take stone models of their teeth and then we try to mount them together on the articulator, we run into some trouble, right? So in the case where the patient is biting together, well, the lower teeth are connected to the mandible, and that's connected via muscles, and you have the ability to close your teeth together without things tipping. When we're trying to do it and trying to put the stone models onto our articulator to mimic what the jaw does, well, we're going to have to fight gravity in a sense, right? The back of those teeth don't have enough stable contacts to form a tripod, and under just the weight of gravity, that upper cast is going to tip, and we're going to get an inaccurate relationship of the distance between the upper teeth and then the lower ridge or the lower gum tissue. Okay, so we're lacking posterior stops. So one of the things you always want to ask yourself is, when you look at a patient's clinical scenario and how their teeth present, you always want to ask yourself, am I able to hand articulate these models and form a stable tripod? Meaning, can I take those two models and just put them together, and essentially even just take your hands off of the models, and it'll remain in a very consistent, stable bite. So you can imagine, if the patient has all their teeth, upper and lower, you can essentially just drop that upper cast onto the lower cast, and it'll just sit there in a stable environment. But if you put this upper cast in this situation onto the lower cast that's missing all their posterior teeth, the upper cast is going to tip down. Okay, so this would be a case that you cannot hand articulate together. So we talk about hand articulation. We're really talking about our ability to mount these stone models onto the articulator. It has nothing to do with what we see in the patient's mouth inside. It's the fact that once we get stone models of their teeth, can we put them in the correct spatial orientation relative to each other? Okay, so we have methods to help stabilize bite, and we're going to construct something called a wax rim, and you've seen this in a full denture case, but we're going to do this in a removable partial denture kind of scenario. So what I'll do is I'll leave you with one last little clip that kind of explains some of this. So this video clip is from Dr. Maroos. He's one of our pros faculty here as well, and he will be teaching your removable partial denture course. So this is one of the videos from his classes. The other thing we're going to do in the sim clinic is we're going to explore these two concepts. One, our ability to hand articulate. So we're going to have a set of models that you're going to be able to try to determine whether you can hand articulate or not. So there'll be a bunch of different clinical scenarios. At the same time, there will be another project where we're going to show you, the sim clinic instructors will show you how to construct and use a wax rim so that we can mount the lower jaw accurately to the upper jaw. And along with that, we'll also use that Coyce dental facial analyzer to help you see how the upper jaw gets mounted relative to the hinge axis. Okay. So hopefully after this video and those two exercises, this concept will be a little bit more clear to you.
Mounting a case in MI is usually straightforward. However, if a patient has less than 3 occlusal stops, this becomes a problem. The reason is that when occlusal stops are less than 3, the cast becomes unstable and finding an accurate mounting position is hard to achieve. Let's take this case for example. Here is one occlusal stop, and if we go around, we'll find that there aren't any more occlusal stops. If we try to bring those casts together by hand, we'll find that finding an accurate position is not possible, as these casts tip over the one occlusal contact that exists. So how do we solve that issue? Record bases and occlusal rims are the solution to this problem. The occlusal rim is made out of base plate wax, and the record base is made out of self or light cured PMMA. They work by restoring the missing occlusal stops, therefore making it possible to mount a case with less than 3 occlusal stops. Record bases are made on the diagnostic cast, and then a wax rim is made on top of that. They are both taken to the patient's mouth. The wax rim is then adjusted so that it does not interfere with the patient's occlusal stops. A bite registration material is used, and the patient is instructed to bite down. After the bite registration material fully sets, the complex is removed and replaced back on the cast, where it can be used to remount the cast.